So I'll just give a brief overview of brain tumor imaging and some concepts, recent concepts. Though, so most of the students I understand is from a psychiatry background. So it will not be in. I mean, I'll just try to give a overview of what kind of lesions are there and what is currently happening in the field of tumor imaging, and how do we approach a problem. So I'll just give an overview about the classifications, imaging methods, which includes regular conventional MRI as well as the um, uh, advanced imaging, some molecular markers, and some example cases. So whenever we get a case of a lesion, so the first question which comes is, lesion is a tumor or not a tumor? So that's how we have to see. So whether scan is normal or abnormal, and if it is abnormal and we find a focal space occupying lesion, so it's a tumor or not a tumor. So for example, this is a 77-year-old female with presented with a giddiness and headache for 1 week duration, and you can see the MRI. So so you can see these are the top are the flare images and below are the T2 weighted images. So on flare images, you can see these are basically a T2 weighted image with a fat suppression, water suppression. So you can see that there is some hyperintensity seen in the right side involving the insula and also the right thalamus. Some signal changes are there. You can clearly see the signal changes are there, which are involving both, probably involving the cortex, which is much better appreciated on T2 weighted images. Overall, rest of the brain looks normal apart from some sulcal prominence, but patient is 77, so it's a age-related atrophy, and you can see some cerebellar prominence, the folial prominence is also there. It's a diffusion weighted image. These are basically T2 weighted images in which which have been diffusion sensitized. They measure the Brownian motion. So anything which, when there is a diffusion is less, means free water motion is less. So this is an indirect indicator of more aggressive lesions and tend to indicate the higher cellularity within the tumor. So that's what is commonly perceived in cases with of brain lesions. But if the necrotic portion leads to shows diffusion restriction, it has many meanings. It can be an abscess or it can be an hematoma in a subacute stage. So look at this diffusion. There is some hyperintensity present. Not much of contrast, and this is a T1 weighted images on which contrast has been given. You can see the blood vessels are showing prominent, well, they are enhancing. Some of mild meningeal enhancement is there all around, and not much enhancement of the lesion is seen. So these are the gradient images. These are again T2 weighted images which have been sensitized to detect blood or calcification. So we can see there's no blood or calcification within the lesion. This patient also, and this is a perfusion scan. You can see this lesion is markedly hyperperfused, means increase CBV within the CBF within the lesion. Okay. Compared to the opposite side, you can see how the other side and the cerebellum looks like. So this is so with these information, so one of the problems was that we were not sure whether it's a lesion is a tumor or not a tumor, because similar kind of because there was a thalamic lesion as well as there was a cortical lesion. So both were not in continuity with each other. Sometimes this kind of signal changes can happen in some of the conditions, like after the seizures. You can have a patient has a seizure, he can have some signal changes which can involve cortex, can involve thalamus, hippocampus. These are some of the areas which can get involved in the post-seizure activity, and they can also show hyperperfusion. They can show absence of, they will not have any susceptibility. You can see here these venous structures are totally absent here. So all these findings can be seen in those conditions as well. Autoimmune encephalitis is another condition in which you can see similar vague signal changes involving the hippocampus, thalamus, basal ganglia, cortical, which may not have, which can involve both hemispheres, may not be in continuity. And they also, because can have seizure presentation, they are subclinical interictal activity. They can also show hyperperfusion and can mimic a tumor. So these are the problems which we face, and sometimes the answer lies in the imaging, and sometimes we can just wait for some time, because tumor will tend to grow rather than regress out on its own, whereas these kind of signal changes which happen after the seizure, or after, in case of autoimmune encephalitis, they can actually settle down a bit. Hello, can you hear me? So these can, so this they, so this is this differentiation is important. For example, in this particular case, we got a clue from the CT scan. So it's not that always an MRI will give you an answer. Sometimes the CT scans can also give you a clue. I'll give you some of the examples of that. For example, in this particular case, an old CT scan was there, which showed a focal lesion which was looking hyperdense. You can see this is the cortex, which also looks hyperdense slightly compared to the white matter. But this is coming in the white matter. So this lesion is, there's some lesion present. And you can see some amount of, here the sulcal spaces can be seen much better. Here the sulcal spaces appear, looks slightly effaced. So with this, if you put everything together, it's likely to be a tumor. It was actually biopsied and found to be an oligodendroglioma. So this is how we can approach a problem. This is the next intraaxial tumor. Coming to the next one, sometimes you can have lesions which can mimic a tumor. This is another condition which can have a ixole-like presentation, but they are not actually ixoles. So this is a condition. It's called demyelination, like multiple sclerosis and MOG antibody disease and disease. So which can have large tumefactive lesions. For example, in this particular case, and if they are in young, then okay, we have some we can, the age is the one which gives us a clue. But when it is on older patients, then we start thinking about metastasis and glioma, and many times I've seen these patients get operated. But but they also have very some salient features which can help you to diagnose. For example, in this particular case, this is relatively young patient. It was only, I think, 23-year-old patient. And you can see multiple areas of hyperintensities there. And look at this particular lesion. Actually, you can see there's a central area which is looking necrotic, and there's a peripheral zone of hyperintensity. And but after that, it's a very sharp zone of demarcation between the lesion. And on, if you look at the opposite side, there's another lesion which is showing, appearing hyperintense. In diffusion weighted image, and on T1, you can see the center again looks very rarefied, very hypointense here. And there is a hypointense lesion around it. On diffusion weighted imaging, you can see there's a rim of diffusion restriction which is present there. Again, this lesion here also you can see a rim of diffusion restriction, means it's appearing hyperintense here. And on ADC map, there's a blackness which is in the margins. You can see one black zone in the margin. Here also it is black zone in the margin. And in intermediate structures are showing some hyperintensity here, for example, in this area. So this kind of peripheral zone of hyperintensity and then central necrotic area which shows diffusion restriction pattern of this type. And if we go contrast to these patients, this will show a vague enhancement. The same exact area which is showing diffusion restriction will show enhancement. And also the morphology of the lesion is very unique. This necrotic area, if you see, the more signal changes are, it is this, the most necrotic part is towards the cortex. It's actually extending into the subcortical U fiber zone, whereas the part which is hyperintense and has got some long transition zone is towards the white matter of the brain. So this morphology, diffusion weighted imaging, contrast study, everything gives a clue. And usually they will have a very short history. So that will also, so clinical evaluation also plays an important role in which context we are looking at the image. So this is a case of a tumefactive demyelination which can mimic a tumor. Okay. So coming to this another case, this is a child, again a child. You see this particular patient having a large necrotic, a large hypointense mass in the frontal lobe, with a lot of edema around it. And surprisingly, there's no bleed within this lesion and looks very dirty on this T2 weighted image. So this is a flare, this is a T2, this is a flare, this is the diffusion ADC map, this is diffusion weighted image, this is the SWI, and this is the T2 weighted image. So basic, you look at the T2 weighted image, this shows very hypointense, very hypointense, dirty looking mass lesion, which is intraaxial. Okay. and causing a lot of mass effect. Midline shift is there. Ipsilateral lateral ventricle is not seen. Contralateral lateral ventricle looks dilated. So there's probably an obstruction at the level of foramen of Monro. And so when we see a lesion which is very hypointense, so we expect on diffusion that lesion to show at least a signal like the brain. But in this case, it's showing a signal somewhat like of water. It's a very fluidy signal. But on T2, it is very hypointense. So normally a T2 hypointensity in cases of mass lesions is indicative of a highly cellularity of the lesion, because more cells are there. They are mitotic lesions. And so when more cellularity is there, diffusion should be restricted. The fluid should not be. So here in the diffusion weighted image, it is opposite behavior. The lesion area is showing a behavior similar to the CSF. So if you look at the contrast and the T1, so this is a T1 weighted image. On T1 weighted image, the peripheral zone of the lesion, the margin of the lesion is looking hyper intense. And this is the magnetization transfer T1 weighted image. No need to go into all those details. It's a quantifiable sequence, which is basically magnetization transfer pulse has been applied on top of a T1 weighted image. So basically, it's a T1 weighted image with the magnetization transfer. When we apply this sequence for certain lesions like multiple sclerosis, it is useful, and in cases of suspected tuberculosis, it is useful. So in this particular case, center part is again looking necrotic, but the T2, it is not looking bright. That is the odd. So this is a clue that this is not a mass lesion. A mass lesion, we would have expected this particular area to be cellular, not show this kind of diffusion characteristics, and should have shown enhancement. Whereas here the enhancement is coming all along the. This is a post-gadolinium T1 weighted image. So all the enhancement is coming at the margin of the lesion. Central part is necrotic, but the necrotic part is looking T2 hypointense. So the necrosis showing a T2 hypointensity without any hemorrhage, indicative of a tuberculoma. And also the peripheral zone of T1 weighted images gives you a clue that it is a. So this is called empty effect of tuberculoma. You can read about it. So look at the spectroscopy. In this particular case, we have done a spectroscopy. In this spectroscopy, if you see, the voxel has been placed in the necrotic part. So what is happening? Only one tall lipid peak is there. This is because the tubercular wall has got a lot of mycolipids, which is being captured by spectroscopy, and you can see a large lipid peak with other resonances just been dying out in the background. Okay, this is the perfusion scan which we have done. This is a contrast enhanced perfusion scan where you measure the CBF and CBV. Because it's an infective lesion, not much angiogenesis is there in these lesions. These are not. So tumors have tendency to have a angiogenesis because new vessel formation is happening. So they tend to show a larger CBV and CBF values, but in this particular case, hardly any CBV and CBF is there, because these lesions, tumefactive demyelination, tuberculoma, they tend to show a very low angiogenesis with few exceptions. Sometimes you may get some cases where high angiogenesis is there, but mostly this rule is that the low perfusion is a rule in case of tubercular infections as well as the tumefactive demyelinating lesions as compared to the neoplastic, high-grade neoplastic lesions. Now, next question is whether the tumor is intraaxial or extraaxial. That is an important question because it determines a lot of things. So in extraaxial lesions, usually in the convexity, are easy to remove. Okay, and they have a much better prognosis. So look at this particular case. This is a T2 weighted image. You can see there's a lesion present here. Now you can see around the lesion there's a hyper intense small areas are coming. You can see here around the lesion there are small hyper intense areas are coming. This means there is a CSF surrounding the lesion. This is called a CSF cleft. Also, look at look at this, some of the vessels, you have to look at the vessels. For example, a vessel is seen here, small flow wide of a vessel. This vessel is displaced towards the brain. Okay, that's another point. What is the where is the cortex? If you look at this is the lesion, you can see there's a cortex here. Adjacent brain is having a cortex, which can be appreciated here. So cortex is pushed towards inside. And sometimes you can see at this location, slight widening of CSF spaces there. In this case, it is not very characteristic, but in sometimes you will see a, because when the lesion is extraaxial, it will push the brain and the focal widening of CSF space will happen. So presence of a CSF cleft means CSF surrounding the lesion all around, the vessels being pushed towards the brain by the lesion. Okay, and the presence of a gray matter lining the CSF cleft and the subarachnoid space widened at the margins of the lesion. These are some of the clues which say that it is an extraaxial lesion. It's not an intraaxial lesion. Okay. Now coming to the next point here. So in this particular case, lesion is present and you can see the adjacent dura is also thickened. You can see the adjacent dura is also thickened. So when this is a contrast enhanced Stephen weighted image, and also you can carefully see the cortex is there adjacent to the lesion, and CSF space here is widened in this location. Okay, so this gives us a clue that this is an extraaxial lesion. Lesion is lying outside the CSF space, means outside the, it is either coming from the dura, coming from the cranial vault, or coming from the, not from the brain parenchyma per se. So that is an important discrimination here. So you can see in the zoomed view, this is the lesion, this is the CSF cleft, brain is pushed here. Can you see? And there's a gray matter coming here, which is just adjacent to the lesion here. And lesion is lining, is strongly enhancing, and the adjacent dura is thickened here. You can see this one. Correct? So this gives us a clue. And sometime adjoining bone will show changes. Bone will show maybe show some sort of hyperplasia, or it can the extraaxial lesion can be coming from the bone itself, or a meningioma can be invading the bone. So these all are additional clues. A glioma will rarely invade the dura. Gliosarcomas are known to invade the dura, but other tumors, among the other tumors, most commonly the gliomas do not invade the dura. They will not be going outside the cranial cavity. They will not be invading the bone if there's a bone destruction. And usually also look at how the bone changes are there. Here you can see the bone is there. You can see the bone. This is a dark black thick line here is the bone. The lesions which are slow growing, for example, meningiomas, or other lesions, or the intraaxial lesions also, which are very slow growing, will start causing the erosion of the bone, smooth erosion of the bone, without causing any destruction, causing a mass effect on the bone. Whereas those which are rapidly growing lesions will either invade the bone, destroy the bone, or they will cause a mass. They will not be remodeling the bone because they will be rapidly growing. Now coming to another case. Here there is a left frontal lesion. You can see now the bone here and the bone here. This bone has been remodeled. There is a, look at the bone up to this place, but the other side bone is there. Lesion is smoothly merging with the brain areas, with the normal brain. Cortex cannot be discriminated here. So cortex itself is involved by the lesion. Okay, and underlying white matter is also involved by the lesion. Got it? And you can see this is the contrast enhanced Stephen weighted image. You're not able to see any contrast enhancement, but look at the cortex and the white matter here, and look at the cortex and the white matter here. That's all, everything is smushed out. So this gives us a clue that, this is an intraaxial lesion, and it's an intraaxial lesion involving both cortex and the white matter, and is slow growing because this is some amount of bone remodeling happening around it. It is not showing enhancement. Usually enhancing lesions, it's not a rule, but enhancement is indicator. Mostly it is a more aggressive lesions tend to show more enhancement, but there is an exception to everything. Pilocytic astrocytomas are very benign, relatively benign tumors, but do show a lot of enhancement. So intraaxial lesions, findings are, there will be no dural tail, tumor parenchyma interface is not lined by the gray matter, expansion of the gray matter, and there is no So brain parenchyma is not buckled inside. It will be projecting, actually, it will be expanded in this location. You can see the left frontal lobe is expanded here compared to the right frontal lobe. And you can see the sulcal spaces are all effaced on the in the left frontal lobe. So this gives us a clue that it's an intraaxial lesion. So there are now secondary effects of brain tumor. So we call it herniation syndromes. So these are predominant types of herniation: subfalcine herniation, descending transtentorial herniation, tonsillar herniation, ascending transtentorial herniation, and extracranial herniations. So why it is important? So herniations are like, we need to tell them because sometimes they come in emergency and they come with they are in a very sick state at that time. Surgical decisions are based on some of the, for example, presence of a pupillary asymmetry, lack of pupillary dilatation, all these kind of presence of hemiparesis or hemiplegia because of the mass effects, because of the herniation syndromes. So they become indication for urgent surgical intervention. But we need to identify that when we are reporting or when we are looking at a scan, we also need to look at these aspects. So as I mentioned, subfalcine herniation, this is a coronal scan. You can see subfalcine herniation happens around the falx. If there is a bony defect because of the old surgery, the extracranial herniation can happen. Central means the whole brain, supratentorial central brain trends to herniate down. Then there can be uncus, which can herniate the medial part of the temporal lobe into the hiatus here. And there can be tonsillar herniation. And the cerebellum, if the lesion is present in the superior cerebellar area, the tonsillar herniation happens. If it is in the inferior cerebellar region, there can be, superior cerebellar hemisphere, it tend to cause an ascending transtentorial herniation. I'll give you the examples of that. So, so what do we need to know? There's some clinical information is important, like neurologic syndrome. What is the kind of neurological syndrome patient is having? Some history. Anatomic landmarks which we need to identify is a falx, septum pellucidum, dentorium, and foramen magnum, because these are the location where we need to look at the herniations. What is the direction of the mass effect? Analyze the location of the pathology and in which direction the mass effect is happening. Displaced structures. So what are the structures which are getting displaced? Whether the structure is supratentorial, infratentorial, and specific anatomical region, for example, cingulate, gyrus, or uncus. There are some indirect signs like what is happening to the cistern spaces, what is happening to the brainstem, what is happening to the ventricles. Then there are some herniation related complications as well. There can be stroke related to stroke because of the compression of ACA, PCA, pica, these arteries. Cranial nerve syndromes can happen, third nerve palsy and third nerve stretching, and then can be hydrocephalus. So this is subfalcine herniation. This is not a tumor, it's an hematoma, but just for the sake of explanation, this is the most common herniation. You can see this is the region of falx, and you can see that the brain is herniating here across the falx. Okay, and this is because of the mass effect caused by the hematoma, as well as some amount of subdural is present here. Midline shift is happening here. Ipsilateral lateral ventricle is partially effaced. Opposite side ventricle is also partially effaced and distorted by the presence of this. Similar kind of findings can be seen in the case of tumors. But there's a big difference between a tumor and a hematoma. In hematomas, the brain doesn't get time to adjust to the new dynamics. In the sense, see, so there are only three kinds of tissues which are present. One is CSF, blood, and the brain parenchyma itself. So when the hematoma forms, there is hardly any readjustment possible because the expansion happens at a rapid pace, and the midline shift the amount of midline shift becomes very significant. It's a very important factor for determining the long-term outcome. But in case of tumors, because they grow slowly, they have an opportunity to cause a CSF displacement as well as changes in the blood flow of the rest of the brain and the brain parenchyma. So in a closed cranial cavity, there's always a chances of adjustment, which do not happen with the case of hematoma. Coming to descending transtentorial herniation, and one more point, the subfalcine herniation, when it happens, it can lead to the anterocerebral artery infarcts, but these are very uncommon. But this happens because the anterior cerebral artery gets wedged against the falx, which is a rigid structure. Coming to descending transtentorial herniation, it's the second most common type of cerebral herniation. It's called central or unilateral. It can lead to cranial nerve third nerve compression, leading to the pupil, involving third nerve palsy. And there can be so what happens when the uncus herniates? It obliterates the peduncular cistern and the suprasellar cistern, and there can be compression of the contralateral cerebral peduncle leading to Carnot notch or a false localizing sign in form of ipsilateral hemiparesis. And there can be midbrain hemorrhage. I'll show you the example. In this particular case, you can see this is the uncus on the left side. On the right side, there is a uncus is herniating here because of the ill-defined lesion present here. There's a some amount of midline shift happening. You can see the uncal herniation. The peduncular cistern spaces are totally effaced. Normally, you'll see the perimesencephalic cistern and the peduncular cistern here. They are totally effaced. Okay, and also you can see that even the suprasellar cistern space is effaced. The whole brainstem has actually descended a bit down, and there is no CSF can be appreciated around the brainstem, but we know that it's the midbrain region, and interpeduncular cistern also has effaced. So both right uncal as well as descending transtentorial herniation is happening in this particular case. These are tonsillar herniation. When tonsil herniates across the foramen magnum, when there is a lesion present in the posterior fossa, visualization of tonsil extending below the foramen magnum, it leads to anterior brainstem displacement and loss of CSF around it. And fourth ventricle may be compressed, producing an obstructive supratentorial hydrocephalus. In this case, you can appreciate the fourth ventricle here. You can see the tonsils are herniating here. And on axial, you can see the tonsillar herniation present here. And this distance can be measured. If more than 7 millimeters, it is significant. So various kinds of there are so many complications associated with these herniation syndromes: subfalcine or a midline shift, anterocerebral artery infarction. When there is a uncal herniation, there can be PCA infarct. When there is a bilateral downward transtentorial herniation, the whole circle of Willis can descend down and perforate or occlusion, and hypothalamic and basal ganglia infarction can happen. In case of ascending transtentorial herniation, superior cerebellar artery infarction happens. In case of cerebellar tonsillar herniation, pica infarction happens. Among all these ischemic complications, posterior cerebral artery infarction is the commonest one, which is associated with the uncal herniation. So coming to the primary brain tumors, so which are present inside the brain. So this is a WHO classification, recent classification, and so we know that there are gliomas, glioneuronal tumors, and neuronal tumors. So we know diffuse gliomas, which are adult type. They are further of 3 types: astrocytic tumors or astrocytomas, oligodendrogliomas, and glioblastomas. And then pediatric type diffuse low-grade gliomas and pediatric type diffuse high-grade gliomas. And then there are circumscribed astrocytic tumors called as pilocytic astrocytoma, pleomorphic xanthoastrocytoma, Sega subependymal giant cell astrocytoma, chordoid glioma, astroblastoma. And then there is a long list of glioneuronal has got different set of tumors. So, and apart from these primary parenchymal, there can be tumors arising from the dura. Most important one is meningioma, and then there can be tumors arising from the cranial vault or the bony tumors which are coming from the cranial vault. For example, tumors like Ewing sarcoma and osteosarcoma coming from the bones. So now, among the adult type diffuse glioma, so recently there has been a lot of genomic work has happened in field of brain tumors, and there are many tumors which are now characterized by the presence of certain mutations. So previously it was all histology based classification, but after 2016 it is a lot of genetic components have been incorporated into the classification. So it's amply clear that from last 15, 17 years of research has shown that there are two most important molecular markers for glial neoplasms, which everybody needs to know. And these are IDH mutation and 1p19q co-deletion. So IDH mutation is an isocitrate dehydrogenase mutation, which leads to a better prognosis if presence of this mutation is associated with a much better prognosis in patients with astrocytomas. And 1p19q co-deletion, this is the kind, it's a co-deletion which characterizes an oligodendroglioma. So among the brain tumors, which are primary brain tumors, among them the gliomas, there are three kinds of tumors, as I mentioned you in adult patients: astrocytomas, oligodendrogliomas, and glioblastomas. So astrocytomas are all IDH mutant type, oligodendrogliomas are IDH mutant and 1p19q co-deleted, glioblastomas are all IDH wild type. So this is how we classify, and astrocytomas further can be grade 2, 3, and 4. Oligodendrogliomas are grade 2 and 3 tumors, and glioblastomas are grade 4 gliomas. So while grading is important, grade 2 is associated with a better prognosis. They can survive for more than 5 to 10 years, whereas oligodendrogliomas have got one of the best prognosis there. So if grade 2 oligodendrogliomas are associated with a long survival of more than 15 to 15 years. But whereas a glioblastoma, which are IDH wild type tumors and have a very aggressive course, have a mean survival of 1.5 years. So that's why grading is associated with the prognosis. IDH mutation status is associated with the prognosis, because some of these mutations and genetic markers actually characterize the entity. So why do we need this genomic information? This you can see from this one of the studies which came from our center only. And you can see that when we look at the astrocytoma, oligodendroglioma, and glioblastoma, we can see that 1p19q co-deletion is actually virtually present only in oligodendroglioma, is not seen in any of the astrocytoma. And similarly, ATRX loss, which is a surrogate marker of 1p19q co-deletion, is virtually not it's not intact in virtually all cases of oligodendrogliomas, but is affected in most of the patients of astrocytoma. So these kind of markers actually characterize the lesion. And IDH mutation also, virtually all cases of oligodendroglioma actually have a IDH mutation, and most of the astrocytomas also do IDH mutation is present. So you can look at the survival. If you see anaplastic oligodendrogliomas have the best survival. Anaplastic astrocytomas, which are IDH mutant type tumors, have got an intermediate survival. Astrocytomas, which are IDH wild type, which have now considered to be GBMs or glioblastomas, have got a worse prognosis. So you can see the same grade of lesion, presence of an IDH mutation and an histology, how it determines the outcomes. So look at this particular patient one, look at this case. This was a patient who first had a seizure in 2006, continued to take medications, underwent a scan in 2013 when he was found to have a frontal lobe lesion, which was going into the left side external capsule involving the corpus callosum. There was no diffusion restriction, there was no enhancement, there was not much perfusion, not much choline elevation. And look at, so all these, so among the imaging, brightness on T2 weighted images, presence of a diffusion, absence of a diffusion restriction, absence of high CBF and CBV on perfusion scans, absence of contrast enhancement. These 3-4 features indicate that they are likely, I'm saying likely, not the absolute criteria, they are likely to be tumors with a better prognosis, likely to be lower in grade, have a much better genomic information, which will be prognostically make the patient's survival known to have a improved survival, and they will have a much better response to chemoradiotherapy in general. These are not absolute rules, but they are general rules. This patient continued to have this lesion growth. He refused any sort of treatment, but you can see over the period of time, you can see the tumor is growing. And in 2021, look at the bilateral frontal lobes, temporal lobes, as well as X capsules, basal ganglia region, everything is getting involved. It's a huge tumor. And that time he underwent a biopsy. He started developing cognitive decline. And that time the family agreed for the biopsy, and biopsy showed it's an IDH mutant tumor, um, which is a with an a mixed kind of pathology. But ATRX was retained likely to be an oligodendroglioma. Imaging also appears like an oligodendroglioma. So here you see that tumor is involving both gray as well as white matter. Continues to show some cysts within the lesion. It never showed any kind of contrast enhancement, and it was very slow growing. So from 2006 to 2022, patient has survived for 17 years without taking any treatment. You can see, and they can present, and this is the frontal lobe lesions. They can present with a lot of psychiatric manifestations. They tend to have a lot of psychological abnormalities, and they later on, when the lesion becomes very large, they can have a cognitive decline. This is another patient. This patient has a left side large hemispheric lesion, which is involving both frontal and the parietal lobes. It is causing mass effect. Look at the insula here. Look at the insula here. The insula is getting depressed here. It is going into the external capsule, causing mass effect on the ventricles, which are displaced. There's no diffusion restriction present, no hemorrhage within the lesion. So presence of a hemorrhage also is an adverse, means tends to grade the lesion on a higher grade and a poor prognosis, but these are not absolute. That's what I'm going to emphasize here. Not much enhancement here. He was diagnosed in 2019, but he reported to have a seizures, multiple episodes of loss of consciousness, but he never got himself investigated. He was a doctor himself. Then finally was diagnosed to have this big lesion, which was probably present for a very long time. And if you carefully see there, you can overlying bone also show some sort of remodeling. Look at the bulge here compared to the opposite side. So look at this one. This underwent a surgical resection in 2019, subsequently received chemoradiotherapy, and you can see the mass effect has virtually disappeared now. Very small amount of areas of signal changes are there, and on T1 you can barely see any enhancement here. So this patient has responded very well to chemoradiotherapy, and this is subsequent scans. Now in the last scan in 2021, he has started showing some small area of enhancement. I think probably there is a recurrence happening at the margin of the cavity. So this patient shown excellent response to chemoradiotherapy, has been there for, and the lesion has been there for some time. So indicates that it is probably a tumor which has got a very favorable radiogenomic, the genomic and histomolecular features. So again, this was an astrocytoma with an IDH mutant type. But so in this, compared to the last case, which is an oligodendroglioma, this patient has already within 2 years, he has shown an excellent response to therapy, but again some recurrence has started appearing here. So so these patients, so that's what I was trying to tell, that so both histology as well as the genomic information plays the role. This is another patient. Look at this lesion. Whatever cases I have shown till now, our last two cases were very homogeneous, but this case, it's a very heterogeneous case. Look at the signal changes. There are some more signal changes away from the lesion, far away from the primary lesion site. And you can see there's a high perfusion, high choline. Other metabolites are virtually absent here. Lot of hemorrhages within the lesion. And there's a lot of diffusion restriction, brightness on diffusion weighted imaging, and ADC showing same area as black. So this is the indicator of diffusion restriction or high cellularity, and contrast shows necrosis and very dirty looking appearance of the lesion. Part of the lesion is enhancing, part of the lesion is not enhancing. Some areas are showing necrosis, some are cystic in appearance. So this is the case which underwent resection, complete resection, whatever possible, the left temporal resection was done. Subsequently, other lesion started growing up. Look at this particular lesion, which was there in the previous scan also. You can see this was the size of the lesion initially. Now it has grown up, and the primary site is also showing a recurrence. And subsequently, in 2020, after a few days, he had spread all across the brain. You can see the signal changes, not only in the left temporal, but in the opposite hemisphere, corpus callosum, ipsilateral hemisphere. and there was enhanced ependymal enhancement here appearing here. So this indicates this a tumor is present at the local site, as well as it has grown, it has gone in all over the brain. So it was a case of glioblastoma, which is IDH wild type, and has got a very high MIB indicative. All the indicators, both imaging as well as histomolecular indicators, indicative of a very aggressive tumor. So this is another patient. Here you see the lesion is very well circumscribed, low, small lesion, not much edema is there. Usually higher grade lesions tend to show much more edema, and they are very poorly circumscribed compared to the aggressive lesions, compared to the well circumscribed lesions of lower grade gliomas. So in this particular case, you see the well circumscribed lesion, not much edema is there, but lot of hemorrhage is there in the lesion. This patient underwent a resection, and histology showed that it was a GPM. Now this patient developed another lesion on the right side temporal lobe, which was again, it is a very high perfusion, very strongly enhancing, again showed glioblastoma IDH wild type. Then he had a recurrence in the right frontal lobe, subsequently had a recurrence in the right temporal lobe, again after the initial resection. So within few years, you can see that patient has actually had a multiple recurrences in the brain, and everything is, histology is showing glioblastoma. So this is the aggressive course of the lesion, which is determined by the histology, which is a glioblastoma, which is characterized by microvascular proliferation. That's why you see a lot of perfusion in these lesions, as well as necrosis, which can be microscopic necrosis on histology, or can be macroscopic necrosis visible on the brain scans. And because of vascularization, you can see a lot of leaky blood vessels, and you see a lot of hemorrhage, as can be seen in this particular case, as well as the previous case. Both were glioblastoma cases, and it has got a much worse molecular profile in form of IDH wild type. Now, coming to another case, you can see there's a lesion which is relatively poorly marginated. Apart from here in this location, looks good margins, but anterior and posterior, it's a very poorly marginated lesion, no enhancement. He was planned to have underwent initially didn't undergo any treatment, subsequently underwent a treatment. Only a part of the tissue could be removed safely, and he was doing very well for 6 years. He didn't had a much problem, but then during the COVID, he came with this particular scan, and when subsequently he one day came to the casualty, when the scan was done, showed a lot of hemorrhages. So this is a transition of a low grade glioma into a high grade glioma. So it has become a glioma grade 4 IDH mutant, shows a necrosis, hemorrhage, high perfusion. Unfortunately, that image is not there, but look at the hypointensity of the lesion, lot of edema in the right cerebral hemisphere. So this is a primary, it has now turned a low grade lesion, relatively low grade, grade 3 tumor has converted into a grade 4 lesion with very poor prognosis. So can imaging decipher histomolecular information? Yeah, imaging can decipher histomolecular information. It can give you information about the histology. It can give you information about the tumor grading, and even the molecular information, as I've shown some of the cases. So how do we, so we know where the lesion is located, what kind of features it has. Based on those features, we say that, okay, it can be ependymoma, it can be astrocytoma, it can be I will give you some of those examples. But molecular information, can we capture that molecular? Yes, we can capture with that information based on some simple observations or more complex observations. For example, lesion is located in the frontal lobe, likely to be an IDH mutant tumor. If a lesion is located in the midline involving a thalamus or a pons region, it is likely to be a midline glioma, which are characterized by the H3K27M histone mutations. Involvement of certain structures like corpus callosum, cortex, and ependyma. That also gives you a clue. Usually the glioblastomas, which are towards the cortical surface, I actually have a much better prognosis, have got much less aggressive molecular features compared to the tumors which are present near the involving the corpus callosum or reaching the ventricle margins. Presence of a CSF spread, for example, presence of a CSF spread indicates a pretty advanced disease. CSF spread is a feature of some of the tumors. For example, medulloblastoma in children tend to show a lot of CSF spread. Ependymoma can show a CSF spread, and even the high-grade gliomas can uncommonly show a CSF spread. Characteristics. So, for example, multiple lesions. So, multiple lesions is a more common feature of high-grade glial neoplasms. T2 signal, low signal on T2 weighted images indicate to a slightly aggressive tumor. Heterogeneity within the tumor is also an indicator of an more aggressive lesions. Diffusion restriction is an indicator of aggressive lesion. Okay, then you can do a mass spectroscopy and quantitative analysis. I will not go into those. For example, this simple observation. This is a case which had a lot of calcification in a neoplasm. So presence of a calcification within a neoplastic lesion is an indicator that it is likely to be an oligodendroglioma, is likely to have a 1p19q co-deletion on genomic analysis. So calcification within an intraparenchymal lesion, and especially the gross calcification, like in this particular case, is an indicative that it's unlikely to be an oligodendroglioma. But we must be very careful when we are looking at all those. We did one analysis where to compare the oligodendroglioma and astrocytomas, and in our analysis also, so one of the oligodendrogliomas which is characterized by 1p19q co-deletion, and astrocytomas are characterized by by the presence of IDH mutation along with the loss of ATRX. So these two kind of lesions, astrocytomas are associated with the worse outcomes as compared to oligodendroglioma, and we found that only calcification was one feature which could discriminate the two. Sometimes IDH mutation status can also be predicted by looking at a T2 and a flare images. We call it T2 flare mismatch. For example, here the lesion is looking T2 very hyperintense intraparenchymal lesion, and on flare a lot of inversion is happening. On T1 it is looking very hypointense. So these features, so T2 hyperintensity, flare, it is showing some areas of inversion or T2 hypointensity. So this is called T2 flare mismatch sign. The indicator of this is the feature which is suggestive of an IDH mutation within the tumor, and also these lesions tend to present in the frontal lobe. So this present in the frontal lobe. So this is the location and IDH mutation status. You can see the IDH mutant tumors tend to involve the corpus callosum, frontal lobe, more on the right side as compared to the left side. So you can see they are involving less eloquent areas of the brain as compared to the mutant tumors, which wild type tumors, which tend to present on the parietal lobes, temporal lobes, distributed virtually throughout the brain, with some relative sparing of occipital lobes, involving left insula as well as the right insula. So these are the more eloquent. So left side brain with especially the language areas more tend to get involved in patients with IDH wild type as compared to the mutant tumor. So location and location as well as the mutation status have got a relationship with each other. Then advanced techniques like perfusion, IDH mutant tumors tend to show lower perfusion. They tend to show in terms of diffusion also, they tend to show a higher diffusion values, higher ADC values as compared to the wild type tumors. These are more quantitative methods. So now coming to the example, this is another this case I showed you. It's a IDH mutant tumor. You can see it's a IDH mutant tumor. You see the diffusion, the flare mismatch sign is present. T1 hypointensity, no blooming, no gradient. Diffusion restriction is not there. Some hyperintensity at the margin is there, but definitely the center part is not showing anything. There's no enhancement, no perfusion. But an odd point, choline creatine peak is pretty high. So this is an exception. So every case will not have all the features which will match your understanding. So this is like, it's an IDH mutant grade 3 tumor. Look at this particular case. This it's a relatively higher grade lesion which shows higher perfusion, shows enhancement, shows diffusion restriction. Here, look at the diffusion restriction. This is looking hyper intense on trace maps, and the ADC map shows lower value. Not much of blooming is there as such, but on T2 you can see some areas of T2 hypointensity or isointensity have started appearing within the lesion, which are showing enhancement. So some features are suggestive of a higher grade lesion. This IDH mutation can be directly detected by a spectroscopy by if you can detect the hydroxyglutarate peak in the on the spectroscopy. This was a this is a very tiny peak which comes which overlaps with the glutamate peak. So very difficult to detect. This is a very specialized method and requires a very big tumor in which a large voxel can be placed. But this is the potential method. There are many papers which have actually emphasized the usefulness of this particular technique. Similarly, histone mutation or the midline location of the tumor is associated if the tumor is located in thalamus, tumor located in pons, these are called midline gliomas, and they are characterized by presence of two kind of mutation, H3, histone 3.3 and 3.1. And I'll show you some examples of that. So 1 second. Okay. So sometimes so newer information keeps emanating. So for example, we used to think that all the IDH mutant tumors, why do not they behave they should have a good prognosis, but some of the IDH mutant tumors were not having a good prognosis. So it was found that those which are having IDH mutation, but they also have a CDKN2AB, another gene deletion, they worsen the prognosis and make them look like a grade 4 lesions. So more information is coming, and more so we are getting the reason, we are able to understand the reasons why certain tumors are not behaving as we expect them to be. So coming to various tumors, so now we understand the adult diffuse glioma, which are the most common primary parenchymal tumors, are predominantly astrocytomas, oligodendrogliomas, and astrocytomas can be grade 2, 3, 4. They are usually IDH mutant type. If IDH mutant type tumor also has a deletion of CDKN2AB, then it becomes a glioblastoma. And any astrocytoma with IDH wild type, and it is an astrocytoma and shows vascular proliferation or necrosis or these genetic modification, they all are clubbed together as a glioblastoma. And oligodendrogliomas are characterized by IDH mutation and 1p19q co-deletion. So they are further of grade 2 and 3. So overall, astrocytomas showed they are typically hyperintense on T2 weighted images. They show a flare which is at least hyperintense in the margins. They are usually well circumscribed, show less amount of edema, usually non-enhancing frontal and temporal lobe in location. They are usually more homogeneous. They show a T2 flare mismatch sign, have a low CBV, have a higher ADC value, and show a lower choline creatine ratio. So these all features are of astrocytoma which are IDH mutant. I give this an example, another example. Look at this marginal hyperintensity. Overall lesion looks hyperintense, but the margin looks slightly more hyperintensity to hyperintensity, not showing any enhancement, hardly any area of restricted diffusion. It's an IDH mutant astrocytic tumor. Whereas in a grade 4, heterogeneous, dirty looking enhancement, lot of necrosis on T2 weighted images, and flare also, it's a very heterogeneous lesion, lot of edema around there, higher CBV values, gives you a diagnosis of grade 4 astrocytoma, which previously used to call as glioblastoma. Whereas a glioblastoma, as I mentioned to you, are grade 4 tumors. As I showed you, they are heterogeneous, presence of hemorrhage, poorly marginated, shows necrosis. They are more often enhancing, show higher perfusion and lower ADC and higher choline. This is another example of glioblastoma. You can see a very heterogeneous lesion. Not much amount of edema is there, but you can see the amount of hemorrhage present. Again, diffusion restriction present. Lot of enhancement present. Lot of CBV is very high. Choline creatine ratio is high. Lot of lipid is present. So this is a case of a glioblastoma. Coming to pediatric tumors, some of them are very focal, circumscribed, like angiocentric gliomas. Another focal lesion is this is a newly described entity, PLNTY, and there can be diffuse low-grade gliomas, MAPK pathway altered, which are usually present in the tectal plates. And these lesions are usually temporal lobe, and these are the tumors which present in the frontal temporal lobe and present with the seizures. So these angiocentric gliomas are characteristically present with the seizures, which are pharmacoresistant. You can see a focal signal change. There will be focal atrophy of the brain, and they will be going right up to the ventricular margins. This is a very good paper which came in Journal of Neuroimaging. This is one of our cases. You can see the lesion is coming right up to the ventricle and shows hyperintense signal, and it's more focal and presents with a seizure, can show enhancement. This particular tumor, PLNTY, is a newly introduced entity. They show calcification on CT scans, present with the seizures, present in the frontal and temporal lobe. These are very small, shortly circumscribed lesions. Not much literature is there on them. Then pediatric high-grade gliomas, as I mentioned to you, if they are present in the midline structures and show this S3K27M mutation, so this characterizes them. Then they can be in hemispheres which have got a distinct mutation which is called H3 G34, it's a distal mutation in the histone gene. So they have a glioblastoma-like features. And then there are diffuse pediatric type high-grade gliomas, which are both H3 wild type and IDH wild type. So they are characteristic glioblastomas, what you see in the adult patients. And then there can be infant tumors within hemispheric gliomas. So this is an example of diffuse hemispheric glioma, which is an H3G34 mutant. Previously, we used to label them as an GBM, but now they are molecularly characterized. And you can see not much perfusion, but a lot of diffusion restriction indicative of a lot of cellularity within the lesion, but not much angiogenesis. And it's a large heterogeneous lesion, not much edema, but involving one right temporal lobe. This is an infant tumor, large hemispheric tumor. And these are the examples of midline glioma. So this is the case of a thalamic tumor. This is it's a mutant type, which is a characterized, which we call as midline, diffuse midline gliomas, H3K27M mutant. And this is a GBM, in which this mutation was not present. So coming to circumscribed astrocytic tumors, you can have a pilocytic astrocytomas. These are distinct entities, each one of them. So most important are pilocytic astrocytomas, chordoid glioma, SEGA, astroblastoma, pleomorphic xanthoastrocytoma, and high-grade astrocytoma with pyloid features. So some of them are very rare, but pilocytic astrocytoma is pretty common. They are usually seen in the posterior fossa, can be seen in the supratentorial brain as well. These are well circumscribed lesion. The classic appearance is a cyst with a mural nodule, but can have different appearances. For example, in this particular case, a lesion shows a central necrotic enhancing nodule. This is a pilocytic. This is the characteristic classic appearance of pilocytic astrocytoma. A cyst is present, a mural nodule is present, which shows enhancement. Not much CVV is there. Not usually some amount of susceptibility might be there, but they show a good enhancement on the post-contrast study. Another case. This is another appearance in which it's a more central necrosis with enhancement all around. This is another appearance, and look at the low CBV in these cases. But when they are present in the brainstem, they can have a distinct imaging appearances. They may not show any enhancement at all and can show a strong homogeneous enhancement. So pilocytic astrocytomas, mostly they are in the posterior fossa, usually happen in the younger patients, but sometimes they can happen in another location where they are commonly seen is in the hypothalamic and chiasma region, where that's another common location for them. They can be seen in the brainstem. They can be seen in the thalamus and the midline structures as well. So this is a very uncommon. So another one, this is a pleomorphic xanthoastrocytoma. This particular tumor presents with the intractable epilepsy. You can see a cyst with a mural nodule. So characteristically, it shows a cyst with a mural nodule. This mural nodule will be towards the ventricle size and can show susceptibility, can show some enhancement and calcification on CT scans. But they can be very aggressive also. For example, this is an grade 3 pleomorphic xanthoastrocytoma with a very large lesion causing a lot of mass effect, hemorrhage, necrosis, and mass effect. You can see and very heterogeneous enhancement. This is an anaplastic variant. Coming to astroblastoma, this is another class of glioneuronal tumors, which are usually seen in children, teenagers, and young adults, and they have a striking female preponderance. They are low to high grade and located in the frontal and occipital regions. Radiological features are non-specific. So again, you can see this is a lesion with a cystic appearance with some calcification being present. And shows some amount of heterogeneous enhancement, which is very dirty looking here, and some susceptibility within the lesion because of the presence of calcification. Whereas another case, you can see that's a more solid lesion, again shows calcification, intraaxial lesion, some cyst-like spaces, shows a lot of hemorrhage within the lesion, a lot of diffusion restriction within the lesion, but not much edema around the lesion. So this is a case of a astroblastoma. SEGA are classically seen in the foramen of Monro location in the patients with the tuberous sclerosis. So in a case of tuberous sclerosis, we must remember this entity. So this is in the classical location. These are heterogeneous lesions lying inside the ventricle. They can show a lot of hemorrhage and susceptibility within the tumor. Chordoid gliomas are typically seen in the anterior third ventricle. They can show a very non-specific imaging appearance, but the location matters. Though have been shown in other locations, but the most common location is anterior third ventricle. If solid enhancing lesion comes in anterior third ventricle, and you are not, and the hypothalamic and the chiasma can be separately seen, we must think about choroidal glioma as one of the possibilities. Uh, some lesions, because of their characteristics like presence of a fat. So when lesion contains fat, we must think about two lesions. One is most common is a teratoma, which is more common seen in the suprasellar region or the pineal region, but they can be seen in other locations as well as. So for example, another lesion with a fat is a cerebellar liponeurocytoma, presence of a fat. Here fat will look like an air, look like will have a very low attenuation on CT scans, which characterizes these lesions. And so that gives you a clue. So fat containing lesion in posterior fossa, think about cerebellar liponeurocytoma. So many ways to characterize the lesions are there: presence of their hemorrhage, presence of calcification, presence of fat within them. Sorry. So, so this is another condition which we must know. This is a multinodular vacuolating neuronal tumor. It's a recently described entity. These are touch me not lesions because nothing needs to be done. They are usually asymptomatic. So if you see this kind of lesions, which small cyst-like lesions present around a sulcus, around the depth of a sulcus, think about MVNT. No need to worry about them because usually they are asymptomatic. Very rarely patient can have seizures and nothing needs to be done. So, but I have seen some patients getting operated for these lesions because they were not correctly identified or diagnosed. So we must remember this entity. If this kind of lesion is present, no need to do anything. So these are usually in adults, more than 30 years of age, subcortical location, usually asymptomatic. And on imaging, there's no mass effect, no edema, no calcification, no diffusion restriction, and there's no contrast enhancement. If there's a lesion in the intraventricular lesions, I showed you already some intraventricular lesion like SEGA is present in a background of tuberous sclerosis, whereas this particular case has a lesion which is present in both the lateral ventricles coming from the septum, which very heterogeneous on T2 weighted images. You can see a lot of diffusion restriction, lot of hemorrhage within the lesion. So think about central neurocytoma. So this is central neurocytoma which is present. It's always intraventricular. Very rarely extraventricular neurocytomas are also described, but they are very uncommon. So these are some of the examples of circumscribed lesion. This is another case. You can see this lesion here, very hyperintense, well marginated, no edema present. These are typically present with a history of seizures. You can see the bone remodeling here. Bone has thinned out here. There's no diffusion restriction. There's no hemorrhage. It's a case of DNET, which is a seizure causing tumor. And this kind of bubbly appearance on T1 weighted images gives you a clue to the diagnosis. Another seizure causing tumor is a presence is called ganglioglioma. These are ill-defined lesion. They can be cystic, they can be solid. For example, this is a solid lesion. They can be cystic, cyst with a mural nodule. They can have a different kind of imaging appearances, but they show enhancement. DNET do not show enhancement. These gangliogliomas show enhancement. They cause seizures. Most commonly, they are present in the temporal lobe. Usually, they are small in size, but they can have a very atypical imaging appearance sometimes and can have an aggressive course as well. So coming to, there's another entity which is called diffuse leptomeningeal glioneuronal tumor. This is a newly described entity. Previously used to call it a glioneuronal tumor of meninges. This is a child who was there, visited different hospitals, put on ATT for very long time. There was a lot of calcification inside the brain. Some people labeled it, I think this patient had some episodes of seizures, as well as he was treated as a case of tuberculosis as well as a cysticercosis. And this is a very distinct lesion which you can, and we got an MRI done for him at our place. You can see this amount of cystic areas within the brain which are just near the cortex. So this is actually that was, and they can show calcification. A lot of susceptibility on MRI can show a lot of cysts. This is a very distinct imaging appearance. Hardly anything else shows this kind of imaging appearance. It's a case of a diffuse leptomeningeal glioneuronal tumor. There's hardly any treatment. They can survive for a pretty long time. I think some centers offer radiation for them, but we should not think them to be cysticercosis. They are actually a tumor. They can have a spinal cord involvement, like for example, this particular case. and they can have a meningeal spread as well. Papillary, so coming to some very uncommon kind of tumors, this is a papillary glandular tumor, which is characterized by the cystic appearance. Usually they lack edema, but in this particular edema is present. This cyst will be around the ventricle. Look at this, is present around the ventricle, can show some enhancement, can show some susceptibility within it. There's no, there will not be any diffusion restriction, perfusion will be very low. This is another case you can see is a cyst, and there will be thin fiber, thin strand-like structures present through it, which will give it. So periventricular location, cystic lesion with thin strands inside it, not showing much enhancement, not much edema around it. Think about this PGNT, which is a papillary gland. Similarly, if you see a solid cystic lesion in the posterior fossa, which doesn't fit into the other tumors of posterior fossa common tumors are pilocytic astrocytoma, medulloblastomas, and ependymomas. But another entity we must remember is that RGNT, rosette forming glandular tumor. It's a solid cystic lesion, can show hemorrhage, can show very aggressive appearances, can show calcification, and distinct satellite lesions away from the primary lesion may also be seen. So this is a case of RGNT. Then there can be ependymal tumors, which include subependymomas, which are usually intraventricular, usually seen in the posterior fossa, and commonly do not show enhancement. Then there can be a myxopapillary ependymoma. These lesions are present right down into the sacral region. Ependymomas and anaplastic ependymoma, these are the other which can be parenchymal and can even be seen rarely in the ventricular. They have also been classified based on the genetics, because posterior fossa are now classified into A and B, as well as supratentorial based on which kind of mutation is present, YAP1 positive, ZFTA positive, and negative for both ZFTA as well as YAP1, and they have a different distinct age distribution. So this is an example of supratentorial ependymoma, large solid cystic lesion, very heterogeneous, usually seen in young patients, can show diffusion restriction, very heterogeneous enhancement. They will simulate an high-grade glioma, and very difficult to make a diagnosis of these tumors per se pre-operatively on imaging. But some of the clues to the diagnosis are they have a well-defined margins. Edema is minimal in these cases. Cystic changes are very frequently present. They can show calcifications very commonly, and ADC values can approach white matter values. So some of the clues to the diagnosis, but it hardly ever, whenever I'm not able to fit any case into any of the entities, I will think about an ependymoma, this kind of exclusionary diagnosis. So then there is a subtype of ependymoma, which was RELA fusion positive ependymomas. They are more cortical based, small, well delineated lesion, and can show all the features of high grade, like for example, hyperfusion, can show diffusion restriction, but the distinct feature is their presence in relation to the cortex. In the children, posterior fossa is a favorite site for posterior fossa ependymomas, and the distinct feature is they are present in the fourth ventricle, goes into the foramen of Magendie. They extend to the foramen of Magendie as well as Luschka, and that gives, and they just model around the fourth ventricular cavity. So this is one of the characteristic features of posterior fossa ependymomas. And they can show calcification, they can show hyperfusion, they can show CSF spread. All those features can be seen. And medulloblastomas, again, of childhood tumors, are further of 4 types: classic, desmoplastic, extensive, and large cell and anaplastic variant. There are some genetic subtypes now: WNT, SHH activated, non-WNT, non-SHH, class 3, class 4 tumors. So one of the most important finding in them is that they are posterior fossa, large lesion, looking hyperdense on CT scan. The most important thing, they are posterior fossa, always present in posterior fossa. They can show hyperdense appearance, and on MRI, they will be usually be located in relation to the fourth ventricular involving the cerebellum. They can show hemorrhages, they can show calcification, they can show a lot of enhancement. And on spectroscopy, so the 2 things which are very important for them is that the posterior fossa location in relation to the fourth ventricle, they show marked diffusion restriction. You can see hyperintensity on diffusion weighted imaging, and ADC will be just black here. T2 signal also is not very bright. They tend to be lower on T2 signal, and they may show variable perfusion. And spectroscopy, only choline peak will be seen, no other peak is seen. So indicative of very high cellularity of these lesions. Even the hyperdense appearance on CT scans is indicative of high cellularity. Another case you can see here, fourth ventricular lesion, looking very hypointense, heterogeneous on T1 weighted images, showing diffusion restriction. Again, you can see some of the hyperintensity here, diffusion ADC showing a black areas and showing enhancement. And you see the spectroscopy is so characteristic, it's very high choline peak is seen and a lot of perfusion within the tumor. Again, hyperdensity within the lesion, and you can see some amount of blood present there, fluid level is present there. Again, diffusion restriction is present here, some amount of bleed is there. So always relation to the posterior fossa. Other embryonal tumor, so medulloblastoma is an embryonal tumor of posterior fossa. So supratentorial, you can have ATRT, then you can embryonal tumors with multi-layered rosettes, which and CNS neuroblastoma, and some newly described entities like CNS tumor with BCOR internal tandem duplication. So I think these are the mostly a pediatric tumors. You may not have much interest in them. So I'll just directly go to the some other tumors which can be very useful for people to understand. So this is the one cases of lymphoma. They are periventricular or basal ganglion in location, can show a bright diffusion, bright enhancement, can show a diffusion restriction. So characteristic they are. Sometimes they can present and on perfusion they will be low, show a lower perfusion, but sometimes they can present with a very poor defined, very ill-defined lesions of brain, very vague signal changes in the brain, and then at that time the lymphoma cells are actually infiltrating the white matter, but there is no mass formed, and the mass appears later on. For example, in this particular case, you can see that initially there was hardly any mass lesion, but you can start seeing some masses here or in over a period of time, and then there was a periventricular solid enhancing area started appearing, and then supratentorial brain, rest of the brain also started showing diffusion restricting solid enhancing lesions. For example, here you can see, and none of them is showing hyperperfusion. So they can start as a very infiltrative, ill-defined lesions and later on appearing, forming masses. So we should be very careful. So supratentorial, supracellular lesions, we know, as I've told you, there can be pilocytic astrocytomas. Another entity which we must be aware of is a supracellular germinoma. These are present in relation to the supracellular cistern space, usually seen in young patients. They can show a CSF spread. Okay, so some brain lesions can appear T1 hyperintense. So we think about melanotic lesions which contain melanin. So for example, this is a case of melanocytoma. So many other lesions can also, so you can have other lesions which can have a melanotic differentiation. But the characteristic about melanotic lesions is that they are T1 hyperintense, very, very hyperintense. You can see the post-contrast and the pre-contrast, hardly any difference between the two. And melanin actually shows a lot of susceptibility. So you can see a lot of bleed-like appearance within the lesion, and T2 hypointensity within the lesion. Choroid plexus papilloma, they are again intraventricular lesions. This frond-like appearance gives you a clue that this is a choroid plexus papilloma, usually a childhood tumor, but can be seen in adults as well. Sometimes tumors may not come with any obvious mass effect. I give an example. So these are one entity which we tend to forget is an Ardeen-Chester disease, which can show a very ill-defined posterior fossa lesions, and which is, for example, in this case, there's hardly any mass-like appearance being seen there. But we got a clue from so many other places. Look at the sinuses here; they are showing appearing T2 hypointense thickening of the sinus wall, which gave us a clue that we are dealing with something else. And there was a supracellular enhancement here. The sinuses were also showing enhancement. On a coronal T2 weighted image, you can see the signal chain extending in the corticospinal tracts, which gave us a clue. And the dentate nucleus involvement bilateral symmetrically. So all this put together, it's an Ardeen-Chester disease. But sometimes histiocytic disorders can come with the large mass-like lesions. For example, this is another case of histiocytosis. Another mass lesion which can present lichen meningioma, extraaxial lesion. It's a Rosai-Dorfman disease. It's again a systemic disorder. You can see this T2 hypointense mass-like lesion present in multiple locations. Another lesion which you must remember is an IgG4 related disorder, which can again show a dural thickening and mass-like lesions. Dermoid is another one which I told you, fat containing lesion. You can see here calcification is there in the paracellular location and fat is present here. Okay. And so brain tumor diagnosis is a challenging problem. Careful reading of images can help in reaching the correct diagnosis. Advanced imaging is useful in selective cases. And some quantitative methods like perfusion, diffusion can help in routine diagnostics sometimes. So I hope that so I acknowledge my colleagues from Department of NIR, Neurosurgery, Neuropathology at NIMANS and residents who have worked to collect these cases. Thank you. I hope